Hi, everyone. We're very excited to have today Shengpu Tang. Shengpu is finishing his PhD.
We are, yeah.
Yeah, I'm gonna.
In a friendly manner.
Whoever is on the Zoom, can you mute yourself? Thank you. Shengpu is finishing his PhD under the supervision of Dr. Jenna Wins. And he does a lot of work in reinforcement learning, clinical decision making. He also does a lot of work on organizing the machine learning for the healthcare community, and we're very thankful for that. And today, Shengpu is going to talk to us about clinical applicable reinforcement learning. Thank you very much, Shengpu.
Thanks to me for the introduction, and I'll start right away, I guess. I guess before I start, I would want to say one thing about what I found most fascinating about New York mathematically, because whenever I come to Manhattan, I get dropped at a precise coordinate, and then I can take the subway that travels north or south, and I'm just fascinated by the design of the city. But other than that, I'm really excited, and it's my pleasure to be here to talk to all of you about my research on enhancing healthcare decision-making with AI, specifically towards discussing our progress towards clinically applicable reinforcement learning. Oh, before I start, I will say questions are welcomed at any time, but I also have time at the end for more Q&A. So decision-making is a crucial component of healthcare. At any instant, healthcare professionals in the hospital are making a wide range of decisions about their patients, from diagnosis to treatments, to care coordination and resource allocation. And importantly, these decisions directly impact the patient's care and their outcome. But unfortunately, human decisions are never perfect. According to the US Institute of Medicine, it's likely that most people in the US will experience at least one medical error in their lifetime, sometimes with devastating consequences. According to a recent report published by the Agency for Healthcare Research and Quality, it's estimated there are over 2 million cases of misdiagnosis-related harms in US hospitals per year. While we cannot eliminate human error, there's a clear opportunity for improvement. And in my research, I aim to use AI to enhance these decision-making processes in healthcare. And in particular, I focus on both the methodological advancements as well as real-world use cases. And in particular, my research takes a synergistic approach between these two aspects. On the one hand, we take inspiration from the real-world use cases to guide the design of novel AI methods. And I've been spent some of my time researching different areas of AI, including reinforcement learning, time series modeling, health data representation, and dataset bias. On the flip side, I have worked very closely with clinical collaborators at Michigan Medicine to take some of the advances in AI to put them into practical use to tackle some of the practical clinical challenges, including sepsis, COVID-19, and healthcare-associated infections. While I would love to tell you about every single one of these projects, today I will focus my time on my contributions in the area of reinforcement learning, specifically these 3 papers. And I'll discuss them in the context of sepsis as an instantiation of the technical challenges that we're addressing. So what is sepsis? Given that I'm talking to the DVMI community, department, most of you should probably know what sepsis is, but just to make sure everyone is on the same page, sepsis is a life-threatening condition resulting from infection. And when the body triggers an overwhelming inflammatory response. Left untreated, it can lead to tissue damage, organ failure, and even death. And in fact, it is the #1 leading cause of death in US hospitals. 2 drugs are primarily used in the management of sepsis, namely fluids and vasopressors. And both of them work to prevent hypotension, which means we're preventing blood pressures from dropping to dangerously low levels. Fluids can increase the blood return to the heart to make sure the heart has enough blood to pump out, whereas vasopressors stimulate the heart muscles and constrict the blood vessels, to maintain blood perfusion to organs and tissues. Because these two drugs work by different physiological mechanisms, they're often used in some combination. But their precise doses and combinations can change over time. Over the past decade, there has been immense progress on using AI for healthcare problems that's focused on predicting outcomes using some supervised learning models. So for example, we can build a machine learning model that can predict what's the patient's likelihood of developing sepsis in the next few hours or in the next few days. And we can use that to rank patients from high risk to low risk. However, these types of approaches may not be immediately helpful for decision-making purposes because they don't directly tell us what treatments should we give to the patient in order to reduce their risk of sepsis and improve their chance of recovery. In contrast, I argue that reinforcement learning is an appealing framework for modeling decision-making problems, such as those found in clinical care. And RL can directly learn what actions to take in order to lead to desirable outcomes. So to make sure we're more or less on the same page with respect to what RL is, let's look at some of the recent examples of RL in practice. So in AlphaGo and AlphaZero, RL was used to learn where to place the next stone in the game of Go in order to win the game. In ChatGPT, RL was used to fine-tune a language model to figure out what tokens it should output next in order to generate a response that users are happy with. Both of these problems are sequential decision-making problems, where we need to decide about some decisions in order to achieve some desirable outcomes. Similarly, we can view healthcare or clinical care through the lens of reinforcement learning. Take, for example, treatment selection, where we need to figure out what treatments to give to the patient next in order to improve the patient's chance of survival. Under this framework, the patient is the environment, and the clinicians play the role of the agent. At every time step, the agent observes the state of the environment through some physiological measurements, such as their vital signs, lab results, or even imaging data like chest X-ray, and then take some actions, which are the treatments. And then observe the effect of the actions on the environment through a reward. Did the treatments help? Did the patient's condition become better? And then this process repeats. Just a quick note on notation. We'll use S to denote state, A to denote actions, which are respectively some element of the state space and action space. And then we'll use R to denote a real valued scalar reward. If we unroll this process through time, we'll get a sequence of state, action, reward tuples. A sequence of state, action, reward tuples, which we will call a trajectory. The goal of RL is to learn the policy that can maximize the long-term outcome. And in particular, in our case, we want to learn a decision-making rule that maps from patient's health state to what treatment we should give them in order to maximize their long-term chance of survival. In the standard setting, researchers typically work in the online RL paradigm, where the RL agent has the freedom to interact in the environment. So in AlphaGo, the RL agent has played millions of games against an opponent, sometimes itself, played the actual game of Go, and then it figured out how to play the game of Go. But surely we cannot do that on real patients. We can't just treat millions of patients randomly and then to figure out what's the right way to treat patients. So instead, we're leveraging a new paradigm called offline reinforcement learning, or offline RL, where we have access to a data set containing past interactions between patients and clinicians. And the job of the RL agent is to look at these past treatments to see what worked and what didn't work, and summarize that into a new decision-making rule for treatment selection that can mimic the behavior that led to good outcomes. Despite progress in the field, existing offline RL approaches are often incompatible with healthcare. And I'll specifically discuss the following 3 challenges. First, in clinical care, clinicians and patients may have different objectives or different outcomes they want to optimize for. Second, the need to simultaneously select among multiple treatments can lead to large action spaces and make learning inefficient. And lastly, the high-stakes nature of medical decisions makes it almost impossible to evaluate any of the policy we learn on real patients. My work has proposed novel approaches to address each of these challenges, and I'll discuss the first 2 challenges in the context of policy optimization, so learning a better treatment strategy. And then the last part will be on policy evaluation. So given the treatment strategy that we have learned from data, can we confidently tell how good it's going to be? It's going to perform on real patients. Let's dive right into the first challenge related to reward. In RL, the reward encodes what's the desirable outcome. So it's really important that we get the reward right before we even start learning anything. But really, what should be the reward in our setting? Should it be long-term quality of life or short-term stabilization of the vitals? What if a patient is willing to undergo an invasive surgery over taking a drug with severe side effects? It turns out designing a single reward that can capture the goals and objectives across different individuals could be very challenging. Not to mention, the goals of an individual could also change over time. So in practice, researchers typically default to a survival-based reward because that's a clear goal and it's easy to quantify from data. However, when using survival as the reward, many of the actions could appear similar with respect to the survival-based reward, when in fact, they're different otherwise. For example, some medications might be associated with high costs or severe side effects. And we call these near equivalent actions. Using a standard approach, we're trying to learn this policy that can map from each state to a single best action, and we'll end up ignoring these near equivalent actions. In our ICML 2020 paper, we propose to learn what we call set value policies, which map each state to a non-empty set of near equivalent actions. In the pathfinding analogy, instead of identifying the single best route, a set value policy can allow us to identify multiple near equivalent routes that can all lead to the final goal. So you might be wondering why this is a challenging problem. It comes down to correctly telling when 2 actions are near equivalent. Because it's not enough to just focus on the short-term outcome or the immediate reward. 2 actions that appear similar at first may actually lead to drastically different futures and different long-term outcomes. So we need to, in order to capture these long-term effects, we need to look at something called the value functions, and specifically the Q values. Here's the standard definition for the Q values, where we assume we always follow the optimal policy in the future. And I can write it as 2 parts. So we're saying the Q value of a state action pair, SA, can be decomposed into 2 parts, where the first part is the immediate reward, so the short-term outcome. And the second part is the best case future and the long-term outcome. And we're assuming the future always follows the optimal policy. So we have a max operator here that's taking the best action, A prime, associated with the next state. We're assuming the best case scenario. However, when we think about learning a set value policy and we're giving users the choice in a set of near equivalent actions, we can't always assume they will pick the best out of that set. So instead, we look at what we call worst case Q values for set value policy. And I bring it similarly as above as 2 parts, the immediate reward for the short-term outcome and the worst case future for the long-term outcome. So given the set of near equivalent actions, pi of S prime, I'm going to consider the worst case, A prime, using the min operator when I think about the future of my current action. of my current action here. Right. So this seemingly small change actually changes the underlying structure of the optimization problem. And past work that tackled a similar setting had proposed a solution based on a mixed integer program that looks something like this. However, their solution is limited in several ways because they require the model-based setting, which means we need to know exactly how the patient's health will evolve and the precise parameters associated with that process. And they also require a discrete state action space. And to solve this mixed integer program, we need to perform an exhaustive search over all the possible set value policies, which makes their approach not very scalable. In contrast, we propose a new solution based on a near greedy heuristic that I've written down here. And all we're saying is that the set of near equivalent actions associated with state S, so pi of S, should be those actions whose worst case Q values are within some margin of best case V star. With this heuristic, we can modify pretty much any existing RL algorithm that can be model-based or model-free, so we no longer require explicit knowledge of the environment dynamics. And we can also accommodate function approximations, so we're not limited to discrete state action spaces, which makes our approach more scalable than the past work. To test our approach, we consider a setting that was proposed in the Nature Medicine paper that's looking at sepsis management, which uses a MIMIC3 electronic health record data set. And in this particular setup, the patient health state are derived from 48 physiological measurements measured at 4-hour intervals. And then the actions are the different doses of fluids and vasopressors in each 4-hour period. And the goal is to learn a set value policy that can map from each state to a set of near equivalent action in a particular action space. And that action space we consider also follows a setup in this paper where we have discretized the dosages into 5 bins. So overall, we have an action space with 25 distinct actions. And importantly, the algorithm doesn't know which doses or which actions are associated with similar doses because it just sees this action space with 25 choices. So after we learn our set value policy, we want to look at what are some of the near equivalent actions that our algorithm has discovered. All right, so we asked this question for each of the 25 actions. Which other actions are near equivalent? So let's focus our attention on this particular action where no vasopressor is used and a low dose of fluid is used. For this action, which other actions are near equivalent? And what we did is we plotted a heat map looking at, in the test set, what's the relative frequency of these other actions being near equivalent. So while the set of near equivalent actions is state specific, here we're looking at an aggregate result on the test set to focus on a global trend. So to unpack this a bit more, let's focus on the leftmost column where no vasopressor is used. When a low dose of fluid is considered the optimal action, using no fluid is considered near equivalent for about 35% of the time. And then for larger doses, their frequency of being near equivalent drops off as the dose increases, which makes sense clinically because for more than 2 liters of fluids in 4 hours to be, it's only similar or near equivalent to low dose of fluids for only a small subset of patient states. We repeated this analysis for each of the 25 actions, and this is the overall picture of the result. To further explain these results, I would like to introduce my clinical collaborator, Dr. Michael Schoding, who's going to tell us more about these results.
My name is Dr. Michael Schoding, and I am a pulmonary and critical care physician, and I frequently treat patients with sepsis.
For people on Zoom, I just want to double check that you can hear the audio. Can someone confirm, please?
Yes.
Yeah, we can hear it.
Great, thank you.
The results of this figure are consistent with what I would expect based on my clinical expertise. So first, take a look at the column first from the left. So these actions correspond to when fluids are administered, but no vasopressors are administered. And you can see vertical bands in each cell, which means that similar doses of IV fluids without vasopressor treatment are frequently considered near equivalent. And this corresponds to what I would expect physiologically, that when patients are given similar doses of a medication, we would expect them to respond in a similar manner. Also, if you look at the second row from the bottom, which corresponds to a low dose of fluids and a range of doses of vasopressor, these actions are also considered near equivalent. Finally, the top right cell may seem a little inconsistent with some of the other results. And it suggests that when the action is to administer a very high dose of both fluids and vasopressors, a near equivalent action may be to do nothing or give no treatment. So this may seem counterintuitive, but it's actually also consistent with my clinical experience. In some very sick patients, no matter what we do, they end up having a similar bad outcome. And that's largely because at the time we're able to treat them, their disease has already become irreversible.
Great. So to summarize, in this part, we have proposed a new approach to learning near optimal set value policies, which are policies that can map from each state to a non-empty set of near equivalent actions. And we're hoping that this approach could help support clinician in the loop decision-making, where given the set of near equivalent choices, clinicians can consider other contextual knowledge that are not encoded in the reward, such as patient preferences or cost and availability of the equipment when making their final treatment decision. Now, before I move on, any questions about this part? Happy to take questions now or at the end.
Does this scale well when this set of actions is really large? Like, because right now it seems like there's like 5 actions, like 25 total, but I get a lot of different actions. How does it scale in terms of forming?
Yeah, I think that's an interesting question. So the question is about the scalability of the approach. I would say mathematically, it should scale, right? And it also depends on the threshold you set to say whether I want to be within 5% or 10% of the optimal to consider that near equivalent. I would say practically, when you think about if we were to deploy this system and like how many choices am I going to give to my human users? That's not a computational question. That's more, I think it really is more of a human-computer interaction question. I would say mathematically it should scale well, but the actual implementation, there's definitely more work to be done there. And we also have some ideas of, let's say we run the algorithm with different thresholds for near optimality, then we can have different sets of different sizes of the set of near equivalent choices that we can pick and choose, and deciding on depending on what the user wants, we can give them a set of different sizes. Yeah.
Perhaps you touched on this and I missed it, or perhaps it's somehow taken care of in your outcome. But in terms of sepsis, early intervention is really important. And so how are you capturing that difference here when you're talking about equivalent interventions?
Yeah, so the question is about the timing and early intervention in sepsis and how that's accounted for in this setup. So I don't think the current approach explicitly models the time horizon where you are in treatment progress. But I will say, because the set of near equivalent actions are state specific. So if we have encoded the time in that state, which I think it does encode the relative time to, for example, the start of ICU admission. If we have encoded that time in this state, then then I would expect that perhaps, let's say, at the beginning of the ICU stay, the set of near equivalent actions are smaller because you need to get the precise treatment right. But as it progresses, maybe you have more flexibility in what type of treatments you can get. But I think that's an interesting thing to look into the data to see what's actually happening. Is there going to be that difference, right? Yeah.
Could you look at how often the clinician deviates from the near equivalent recommendation of the algorithm?
Yeah, I think I have to go back to the paper to check. We did some analysis on the agreement rate relative to the relative to the inter-rater disagreement rate between randomly selected clinicians. And those were similar, is what my recollection tells me. Yeah. Great. Cool. So let me move on to the next part, addressing large action spaces resulting from simultaneously selection of multiple treatments, which we have already seen in the sepsis example, because even though we started with only 2 types of treatment, vasopressor and fluids, we somehow ended up with this pretty large action space of 25 elements, right? And as you think about if we were to scale this up to more treatments, then it's going to blow up exponentially. And we see this all the time in healthcare applications, such as in ventilator weaning. We need to simultaneously control the ventilator status and the sedation levels. And to treat respiratory distress, we need to select among a combination of medications, including antibiotics, steroids, diuretics, etc., in order to address different causes of the different underlying causes of the respiratory failure. And mathematically, we call these factored action space, where the overall action space can be written as a Cartesian product of the sub-action spaces. Now, let's think back to the sepsis example, where let's say I have a data set where certain treatment combinations are not seen in my data set, marked by the red question mark. So using a standard approach, we can't infer about how good or bad that particular unseen treatment combination would be because we have no data about it, right? But given this structure of the action space, is there something more we can say? Because here, even though we haven't seen this particular combination of vasopressor and fluid, we do see this vasopressor dose combined with other fluid doses, and this fluid dose combined with other vasopressor doses. So this structure seems to indicate that maybe we can say something more, rather than saying we have no idea how this particular combination is, right? And that's exactly what we did in our 2022 paper, where we proposed a linear decomposition of the Q values based on factored action space. More concretely, we're saying the Q value for fluid vasopressor combination can be written as a sum of the Q value for fluid and the Q value for vasopressors. Now, this also seemed like a very straightforward approach. And in fact, we're not the first to do this because past work have adopted similar forms of linear decomposition, but they often skipped or ignored this careful consideration of the theoretical question of, does this really work? Or when does this work? Which is the focus of our paper. So first, does a linear decomposition always exist? The short answer is no, right? So the more interesting way of posing the question is, when does a linear decomposition exist? In our paper, we have formally derived the mathematical conditions for the existence of linear decomposition. But roughly speaking, we want the sub-actions, which are the different treatments, to be independent in some abstract dimension of the environment dynamics. And this is the case for sepsis treatment because fluids and vasopressors, as I hinted in the beginning, they operate by different physiological mechanisms and they have approximately independent effects on the patient health condition or health state. So great, that's good news, but there's a caveat because this independence is only approximate. A perfect linear decomposition actually doesn't exist. And if we were to impose this linear function, linear structure in our learning algorithm, then it's going to lead to wrong results and lead to biased estimate of the Q values. Yes,
Can I
Dwayne?
ask a clarification question? So you really mean independent, like statistically independent, or do you mean, or is that also statistically independent findable, or do you mean like we know from knowledge that these two actions are independent of each other?
Yeah, I think on the right, I'm mainly referring to from domain knowledge. We believe that they have approximately independent effects.
But if I could probe on that, clinically, they're not independent.
Right, I guess that's where I'm going, like,
Fluids and vasopressors work together to increase your cardiac output.
Yeah, there are some research showing that their combined effect actually can enhance or be more than their independent effects.
Right.
That's also something we addressed in the paper, which I didn't go into detail here. But actually, let me finish my next slide and then I can come back to that.
Okay.
Yeah, so even without that, like, I think that still falls under the umbrella of approximately independent. But it will, if we were to use this linear structure, it will lead to biased results. So why should we even consider it in the first place? Because it turns out that using a linear function can reduce the size of the function space because it reduces the number of learnable parameters. So in particular, instead of learning 5 squared free parameters per state, we're learning 5 times 2 free parameters per state. And this exponential reduction in the size of the function space can bring down variance by a lot that can overall counteract that small little increase in bias and leading to a better bias variance trade-off and overall better performance. And in the paper, we also discussed the scenario that you were, Noemi and Sarah were referring to, where their combination enhances their individual effects. And in that case, we have found that's precisely the case where even though your estimates might be wrong, it doesn't change the ordering of what's optimal action. I'm happy to discuss more about that afterwards.
Great.
Yeah. So to test our approach, we again applied it to the sepsis management problem, where now our goal is to learn treatment policies. We're not learning severally policies here. We're just trying to learn the best policies. So we compare the 3 different treatment policies, where the first one is the clinician's behavior policy, which is what we observed in the data set, and specifically the test set. And then we have the baseline RL approach that uses the standard Q function, and our proposed approach, which is using the linear Q function. And we compare their estimated survival rate, which essentially reflects the average long-term outcome if we were to use each of these policies on the test set patients. And encouragingly, we saw that our proposed approach led to a modest improvement in this performance measure relative to both the baseline and the clinicians. So beyond looking at this number, we were really curious to see what our proposed approach, what this policy is doing differently that is leading to this difference. So we also, again, took a qualitative approach looking at what treatment combinations are used by each of the policy in a heat map, similar to what I showed before. So on the leftmost figure, I'm showing a heat map of the clinician policy. So how frequently or how many times did clinicians use each treatment combination in the test set? And then in the middle, I'm showing the baseline policy. We see a clear difference in this between these 2 policies, and especially in the baseline policy seems to be ignoring a large region of the treatment action space. That you can see from the top here, it's almost never recommending these actions, whereas clinicians seem to be using these actions a substantial number of times. And in particular, this action or this treatment combination is used nearly 3,000 times in the data set by clinicians, where the baseline policy simply chose to ignore it, pretty much. So this action not being recommended could be that it's just a bad action, right? But when we presented this result to our clinical collaborator, they were really puzzled by this result because surely using a medium dose of fluids with no vasopressor, this should be a reasonable choice for a substantial set of the patients. So it seemed unreasonable that the baseline policy chose to ignore it. And we believe it's because this treatment combination was only seen 3,000 times, which is a small number relative to the size of the data set, that the baseline policy has trouble reasoning about how good it actually is. When we look at our proposed approach, we see that it's used now about 1,000 times. And we believe this is an indication that by considering the structure of the factor action space, our approach is better at capturing the effects of certain treatment combinations and can make more reasonable recommendations. So to wrap up, in this part, we have studied a linearly decomposable or linear decomposition of the Q values based on the factored action space. And we studied it both directly and empirically to show that it can lead to a better bias variance trade-off and lead to better policy performance. Any questions about this part?
I'm just curious, you have the frequencies, but do you have the estimates of the rewards corresponding to the
Sorry,
rewards for the clinician policy corresponding to the state actions combinations that you've shown here?
oh, right. So the question is, do I have the reward or the Q values associated with each of these
Yeah.
treatment combinations? So I will say that this is aggregated over all patients
Yeah.
and all patient states in the test set,
Right.
right? So even though when clinicians are selecting this treatment combination, it's for different patients potentially and patients
Right.
with different varying levels of health.
But
Yes, sorry, go ahead.
I'm just trying to understand the bias variance trade-off a bit more. It sounds like you have a more complex Q value, like Q function when you're learning the baseline policy, and then you simplified it, and somehow the number of samples that you have
For each,
adjusted,
yeah,
But
Yeah.
I'm trying to understand how it distributed that. What's a good way to then try to understand that with respect to the rewards corresponding to each state dimension? How would you visualize it?
yeah,
Maybe this
I would
is a
say,
longer discussion, but.
yeah, I'm sure we can have a longer discussion on this. Like, I will say all of the visualization are kind of like a sanity check, and it's visualizing the global trend, but in fact, when we talk about like the treatment combinations, it's specific to each patient and each patient's state, right? And going back to the previous part, like what is the near equivalent actions for each patient state, that could also differ. So I think there's also interesting questions about what's the best way of visualizing some of this to.
I mean, I could just aggregate over the states and still see this.
Sorry, what do
I
you
could aggregate over the states.
aggregate over
Yeah,
the states?
yes. Under all possible states, like it's like marginalizing all states. I'm looking at the reward corresponding to different actions.
Mhm.
Do you have a sense of? I don't want to derail the conversation, but do you have a sense of the rewards being as high in all of these combinations that the baseline policy did not learn on? I'm just very curious to see.
Yeah, I
that
think
number.
I will try to look into that, but what
Yeah.
we did in the paper is to see. Like, especially in this region where the baseline policy seem to be
Yeah.
ignoring it,
Yeah,
how heterogeneous are the rewards, are the Q values? And we found that it's relatively speaking more
I
heterogeneous
see. Okay.
compared to some of the other parts that are being used.
This is.
Yeah, sorry.
So it seems like the baseline policy is saying, if I were to interpret it, is, you're better off using the vasopressor rather than giving fluids because you're gonna have to take the fluid off. Whereas you can just stop the vasopressor. So what you do is you move along the x-axis to the right first. And then if you have patients who are super sick, you go to the upper right corner where you're desperate, and so you have the maximum vasopressor, maximum fluid because you have nothing else left to do. So that doesn't seem like that might be, like we may have it wrong, and that may be the right thing to do. Now, when I go to the rightmost one, that's where I've decomposed it. Should it be like are we gonna see more of the same ratio per column, the same ratio per row from the way it's decomposed, so that we'll naturally put more in? Like if there's more in the third row on the first column, there'll also be more in the third row in the last column. Like it should be, because we're kind of multiplying the two, right? So
Yeah, I think
we should see more of that, which might be the right thing medically or not, whereas the middle one, you learn, no, you don't do that. You want to go up like this, you don't want to go like across like
I
that.
think you bring up an important point, which and you're right in observing that it's not simply a product of two distribution, right? Because we also constrain our policy to not take actions that the clinicians never did in those particular states. And that's something important in order to constrain our policy to be close to what clinicians are currently doing, that we can evaluate it confidently, relatively speaking. Yeah. I'm sorry for the Zoom question that I missed. It was about the first part, but I'll address it after the talk, or I'll answer, reply to the message after the talk. Thank you. Cool.
Can I ask a very quick question on the slide?
Yes.
Potentially the former one, I think, but so I see the clinician policy, I see baseline policy and the proposed policy, and I have seen that you compared these three things. I understand, I think, how you can compute the survival for the clinician, but the reinforcement learning ones are counterfactual to the data, right? How do you compute their metric using the data set?
Yeah, that's an excellent question. So in this paper, we used off-policy evaluation approaches, and in particular, we used weighted importance sampling, and to compute the value or the expected outcome, expected survival rates for the baseline policy and proposed policy. And we have controlled for these two policies to be similarly close to the clinician policy, that they have they actually have the exact same effective sample size. Yeah, does that help address your question?
I think so. Thank you.
Yeah, great. That's actually a perfect segue to the last part, which is how do we actually evaluate these without testing them on real patients, right? So let's say I've used all the fancy new approaches to learn the treatment policy, and I have this at hand, and I want to get some performance measure so that I can present this model to the hospital leadership or the something similar to the AI clinical implementation committee to get it approved to be able to use it in the hospital, right? So what comes next after I learn this policy? If we think back to how the deployment of a supervised learning model might go, it typically goes through these three stages. So first, we have retrospective evaluation, where we report the model's accuracy on the test split of some historical data set. If that checks out, then we can move on to prospective evaluation, where the model is integrated or it's running in the background in silent mode on new patients and producing those predictions. And we're reporting the model's performance by using those predictions generated in near real time. If that also checks out, then we can finally move on to the workflow integration, where we're using this AI or supervised learning model to drive some clinical decisions. We can think of the deploying RL policies in a similar way, right? And what I've described so far, or just now, is offline evaluation, where we have observational data set about how clinicians have treated patients in the past. And we can use statistical approaches like off-policy evaluation, like importance sampling, to reason about how would the outcome be, how would the survival be if I were to deploy such a policy, if I were to deploy my learned policy, right? But ultimately, that's limited by the data we have. And if my learned treatment policy somehow makes a recommendation of something that never happens in practice, then there's a lack of overlap in my data, and I will not be very confident in my result. Researchers coming from the RL background would think more in the other extreme, which is online evaluation. And they do that all the time on their simulators on the games. They just take your learned policy and then test it in the environment. Right, so in our case, that would mean just taking your RL policy, treatment policy, and then test it on real patients, which is clearly infeasible. Right, so what should come in the middle? Can we do something similar to prospective evaluation? It turns out there's no exact equivalent of silent mode, because RL is interactive. We either change how we're treating patients, and that places us in the online evaluation, or we don't change how we're treating patients, and that's offline evaluation. There doesn't seem to be a good middle ground, right? So what should we do here? And that's exactly what our NeurIPS 2023 paper addresses, where we propose a new semi-offline evaluation scheme. And in particular, we're proposing to combine observational data with human annotations of the counterfactuals, of the treatments that didn't happen. So let's think through this small example where a patient undergoes 3 days of binary treatment. And then on the right, I have their final outcome labeled in red. In our observational data set, we will only observe the factual trajectory that's highlighted in green. And then that will leave the other possible treatment trajectories unobserved in our data set. And those are the counterfactual trajectories. Under our framework, we assume we can query domain experts for annotations of the counterfactual trajectories. So for example, on the first day, we're gonna ask our clinicians to tell us if they were to change their treatment on the first day to the other choice, what would happen to the patient? What would their outcome be? And then we can do that for the second day, the third day, at every decision point. With that, intuitively, this should help because we're just collecting more data about the factual and counterfactual outcomes, right? But it turns out that for evaluating policies, simply adding these annotations as new data points is not theoretically valid. And we had formally showed that that approach of simply adding data to your data set will lead to bias. And instead, we propose a very simple approach using a weighted combination of the factual and counterfactual data to generate the final estimate. And we formally showed that this weighted combination approach can achieve lower bias and lower variance. And we validated that empirically through some simulation experiments where we see our proposed approach led to lower evaluation error compared to the baseline approach. And the evaluation error is the combination of bias and variance. Now, this is under the assumption that your annotations are good. That's essentially saying, when I ask clinicians, what do you think would happen? It's as if they've actually done it to a patient in that scenario. But we know that's not necessarily true, right? So our paper also presented sensitivity analysis that shows robustness against imperfect annotations that could be biased, noisy, or missing. And I'm happy to discuss more about the details afterwards or during the Q&A. But overall, I believe our contributions in this space are important steps that help bring offline RL in healthcare closer to reality. Now, zooming out, I've told you a lot about my work that's in this one arrow of taking inspiration from real world problems to design new AI methods. But what actual clinical impact have we had in healthcare? On that front, I would like to share two of my projects done with collaborations at Michigan Medicine. And these are two machine learning models that are currently deployed at Michigan Medicine. So the MCures model was a model that we developed during the COVID pandemic. And it was originally designed to identify low-risk patients that could be sent to a field hospital. And it's now being repurposed by the emergency department and the rapid response team to identify high-risk patients that could use extra attention during their rounds. And then for our work in tackling healthcare-associated infections, we just wrapped up a year-long pragmatic quality improvement project where we take a supervised learning model that can predict who's at high risk of getting C. difficile infection and using that to target some of our infection prevention efforts in the hospital. And we have some initial results at the 6-month mark that looked pretty promising. And we're really excited to wrap up the final analysis for the 12-month data. And for anyone interested in these two projects, I'm happy to discuss more afterwards. Now, thinking ahead to the future of AI and healthcare decision-making, I believe that human AI teaming is really the key. And I believe that humans should be considered at all stages of our research process, from problem formulation, model development, algorithm design, to evaluation, deployment, and maintenance and monitoring. And not only do we need to involve clinical care teams, we also want to involve the patients, as well as other stakeholders like hospital leadership and policymakers, in order to make sure we're solving the relevant problems and making actual impact in healthcare. And finally, I'm really excited to build interdisciplinary teams at Columbia, including within the medical school and the DBMI, and also with engineering departments and the Data Science Institute to build the next generation of human AI teams to improve healthcare decision-making. And with that, I want to thank my collaborators to date from different institutions without whom all of my research would not have been possible. And with, yeah, thank you. With that, thank you. Yeah, we have a few more minutes for questions.
For questions.
So the question on Zoom was, can you please give some intuition why you use min instead of max in the Q value? So that was addressing the first work on the set value policies. So in the standard Q value definition, we can assume the future always follow the optimal policy. So we're taking the max, which is the best case of our future actions. But in our case, because we're learning a set value policy if you imagine how we're going to use it is given the patient health state or given the patient, I'm going to give the clinicians or the users of the system a set of choices. And we're kind of making them a promise to say, no matter how you pick from the set of choices I give you, you're guaranteed some outcome, let's say within 5% of the optimal. So in order to make that mathematical guarantee, we need to consider the worst case. That's taking the minimum or the worst case action in the set of near equivalent actions. Does that help address your question?
Yes, thank you. It looks like that my understanding is that you provided a safety net for the treatment outcomes you're looking for, instead of trying to have those champions of these treatment.
Sorry, could you repeat that?
Oh, I just said that if I understand your answer correctly, it looks like your algorithm is trying to find a safety net for
Yes.
the patient's outcomes, rather than trying to optimize or trying to get the best performance possible for any particular patients.
Yeah, I think your interpretation is correct, but the actual optimization problem also is about optimizing, learning a policy with good performance. And you can imagine there's going to be some trade-off of if I allow more flexibility at the beginning of the treatment period, then maybe my flexibility would be smaller at the end. So there's some interaction between how much flexibility or what's the size of the near equivalent actions for each state, and that can influence the size of the other states for your overall guarantee of near optimal, right? Hopefully that helps answer your question.
Yes, thank you. If you don't mind, can I follow up another question?
Sure.
So yeah, so I'm just wondering that, okay, so patients, right, they give needs like say fluids or vasopressor. My understanding is that there's a course of action. For example, the doctor might start with less aggressive options like a fluid, and then if it didn't work, they give pressors, right? So I'm just curious that do you have you thought about adding the time variable into your your policy or your optimization?
Yeah, that's a great question. So it also comes down to a problem formulation question, and in this work we're following the setup of the Nature Medicine paper, and they do put the time measured to their starting time. I think it was the ICU admission time. They do put time in their state representation, so that's implicitly accounted for. But there are also other approaches that's looking, for example, at finite horizon Markov decision processes where you can learn different treatment policies for each time step. And I think those are interesting directions to explore to see which actually works best. Yeah, but it is somewhat accounted for in our approach, in this setup, yeah.
Okay, great. Thank you very much.
Yeah. Great. One last question, I guess. Running out.
So, your case scenario here is based on the ICU setting. Is it relatively trivial to apply this to the outpatient setting and decision making? I'm thinking, sort of in the ICU setting, what's available to patients is whatever sort of interventions anyone would have in the ICU. But when you're looking at the outpatient, there are a bunch of other factors like insurance coverage of certain options, things like that. There are other complexities. Have you thought about how this applies to those scenarios?
Yeah, that's a great point. In terms of the math side, I would say these are generalizable methods that could apply to problems even not in healthcare. If you want to learn semi-liquid policy, if you have this vectored action structure, right? But so I've personally only worked primarily with the inpatient and ICU settings in my application areas. I would need to learn more about what the outpatient setting look like and what the data heterogeneity and the patient heterogeneity look like to answer that question fully. Yeah, but definitely important question.